First up, in the Innovation in Care Delivery category, it's team number 1.
Good afternoon. When Paul and I first met, we were trying to determine the number of rectal cancer cases that were performed throughout Northwell. The only data source of sufficient scale to help answer that question was our billing data, which is both structured and easy to access. However, we quickly found it cannot provide the clinical context needed to answer the question. We needed more granular, scientific data. We needed more clinical abstractors like Arlene here. Arlene can read through a patient's chart and manually transform the unstructured text data to provide actionable insight on our patient's continuum of care. But Arlene has a heavy burden. She may need to document over 1,000 data points for a single patient, and this process could take anywhere between 45 minutes to 4 hours depending on the complexity of the case. Because of this time-intensive process, data abstraction is both expensive and prohibitive to scale, and yet every department and every hospital within Northwell Health uses data abstractors. Because of this, what we're trying to do here with Acute is trying to enable data abstractors to work within scale.
So we're excited today to introduce you to Acute, which is a web-based platform designed to improve the accuracy, efficiency, and scalability of this data abstraction process. It does this by taking what's best in Arlene, that is her clinical acumen, experience, and judgment, and marrying it with the efficiency and scalability that artificial intelligence has to offer. And we call this the human in the loop because although the artificial intelligence system is going to learn from Arlene and going to learn how to better serve her, Arlene is going to be the one to make the final decision. But let's take a look at Arlene and examine why it is that her job is so difficult. Well, first of all, you can see that she has 3 screens because she really has 3 separate tasks. Number 1 is she has to find the patient. Then for every single data point, she has to look through the EMR, the electronic medical record, and search for that data, and then she has to manually input it in. But what is it that makes her job so inefficient is the search. Now, if you and I were to perform a search, let's say we wanted to know how many employees does Northwell have, I'd use the best tool at my fingertips, which would be a search engine like Google. I'd put that in, and I might instantly get an answer like 74,000. However, I might also want to know, how did it get that answer? What's the context? And so Google provides that. It also provides links in case I need to find additional information. So keeping that in mind, I want you to look at Acute, and this is what it looks like today. And you can see that the first thing we've done is we've taken those 3 screens that Arlene has to deal with and combined them into a single unified interface so that the patient's already found, she has access to all the notes in the chart, she can see the unstructured text right there in the middle. But more importantly, Acute has already performed a search for every single one of those data points that she's responsible for. So for example, if she wants to find out whether or not this patient is currently a smoker, well, Acute has already identified that there are 5 notes out of 154 where this data might reside. All she has to do now is click on the link. The note itself will appear. The context as to why Acute believes that this is the answer will also appear. So now Arlene, all she has to do is read and identify the fact that this patient is not a smoker, and in the same interface, she'll put that in. And so she can just move on to the next data point. So what we hope is that what Google is to the World Wide Web is what we can make Acute to the electronic medical record. And so with this interface alone, we've seen that the data input process, we've improved the efficiency of that by more than 100%. And using just baseline models, we're seeing improvements of 50 to 80%, although in certain circumstances, we have seen improvements of up to 1,400%. So starting with Northwell, but really for any organization that needs to abstract away unstructured text data, we hope to improve the accuracy, efficiency, and scalability of that process. Because we know that you can do amazing things with data, provided you have good data. And so we hope that you'll allow us to develop Acute so that we can solve this very chronic problem. Thank you.
If I may, this is Lonnie Reisman. I just want to be clear about whether or not this has been deployed yet, and if it has, apart from the efficiencies associated with abstracting the data, has it translated into any measurable clinical or financial benefit yet?
Yeah, we have not deployed it into production. So what you're seeing right there is a prototype, but it is actually interfacing with our current electronic medical record systems. And the numbers that I presented to you, they are what we have found in comparisons between abstractors when they're actually doing the process, but no, we have not yet put it to scale.
And also it is EMR agnostic as well.
Dr. Chung, I have a question. First of all, the results you're showing from the prototype seem to be very impressive. If those could be generated overall in other systems, this would clearly make a difference in both efficiency and effectiveness. What is your next step in terms of commercializing this? What would you hope to use the award to accomplish in the next 6 months?
Thank you. So our next plan would be to, first of all, increase the number of employees. So have engineering, one or two more engineers additionally for this. And in terms of deployment, again, because this is a web-based platform, it is EMR agnostic. It's really actually just, it can utilize any type of text data, is to then deploy it, starting with some of our registries. I'm a surgeon, so particularly in the surgical field, and then to again, demonstrate that we can continue to see the improvements that we're already seeing on a smaller scale.
Thank you so much. I just wanted to ask, in the realm of data security and HIPAA compliance, what are you thinking of doing to mitigate risk?
Yes, that's definitely a question that's all on our minds. So we already have, in Northwell, we already have other platforms that are utilizing HIPAA compliant data on the cloud. And so number one is that we would only be using HIPAA certified backends. And also in terms of the software itself is designed so that only those with pertinent access to the data, just like anyone who's using an electronic medical record, would only have access. So that is one of the things that is already baked into the app.
I had a question about the interface, if you could walk us through that in a little more detail. So what is the extractor actually seeing? This is EMR agnostic, so how am I connecting to the EMR so that the data can be seen in the acute? Also, does the abstractor, are they searching and saying, does this person smoke, or are they searching for the word smoking? Is there a template where this person is doing an extraction for this kind of surgery, so acute knows that these key data points have to be filled out? If you could just walk us through sort of how they're actually using it, that'd be great.
Sure. So what you're seeing there is actually what the abstractor would see in terms of the interface. Obviously, we've only shown the screen in which they are now actively doing the abstraction process, but prior to this, let's say an abstractor is dealing with multiple registries. So first there's a screen which they would go into which registry they're going to pick. And then in terms of how it integrates is that on the back end, all of the notes there are the ones that would be in the electronic medical record. But the way I think about it is the electronic medical record is just a collection of documents that are in some sort of order. So, if Arlene was going to use this, she could actually go through by date, she could go by document type. But in terms of what type of variables are present, that is germane to what type of registry or what type of database you're trying to abstract for. So, we have, in surgery, we have some databases for, let's say, vascular surgery, others for bariatric. So it would be those variables that would be pertinent to whatever task is at hand. But otherwise, the way we envision this is also that there's a lot of overlap between the variables that are, that one abstractor, even though they're a different service, they may need to all know what kind of comorbidities this patient's having. So that would be shared across the board so that people don't have to keep on repeating the same type of task all over again.
Once the data is abstracted, is the extractor storing it in acute? So you have to do some kind of binary yes, no, or somehow to make it go from unstructured to structured.
The data is being stored in whichever system that the healthcare organization or whatever organization wants. So like I said, the way to think about it is that this is an interface, but it also provides models to help streamline that process. But the data storage itself is in the organization. So for instance, with Northwell, it would be on Northwell certified servers for security reasons.
And I was just going to ask you, to the extent that you imported data from outside Northwell or were part of a group creating various databases, I presume there'd be significant applicability in terms of applying the technology to theoretically broader data sets to gain new insights. Is that correct?
I'm sorry, I just couldn't hear the last part of your question.
Just I was correct regarding bringing in data from external sources or combining Northwell with other sources of data and then deploying the technology against a much larger data set for purposes of generating insight.
Right, but you know, one of the things that we have here in Northwell is that we have 23 hospitals, and we already have multiple different electronic medical record systems. So even with just Northwell alone, I mean, we have a rich variety of different data types, all clinical, but that we could also pull into the system in order to also help us better train the models and also better increase the efficiency of the abstractors.
And do you believe this is new art, if you will, and protectable from an intellectual protection standpoint?
Yeah, I mean, there are certain parts of it which are definitely being widely used already. I think what makes this platform unique is that, and these are things that we haven't really gone into, but there are other parts such as the audit trail. How do you know that the model is doing the right thing? How do you know some of our regulatory databases? We have to have you have to have a comparison between different abstractors already, and in terms of making sure that the quality of their abstraction process is good. So a lot of that is baked in so that there can be already this automatic comparison. And so there are a couple of things. We are using both a combination proprietary as well as open source software that allows for commercialization, but it's more some of the processes that will, we're working with the ventures to have that protected.
Excellent, thank you.
Well, thank you so much, Team Acute. That's our time. So I think we will wrap up. Thank you again.
Thank you.
Thank you.
Thank you, everyone.
Great start from team number 1. Next up, in the care delivery category, it's team number 2.
Hi, I'm Jamie, and I'm a doctor.
And I'm Theo, an AI engineer.
They say that sleep is one of the best medicines, but as a physician, I have a disclosure. It's one of the hardest things to prescribe. Hospitals are notoriously the worst places for peace and quiet, rest and recuperation. With frequent overnight monitoring and vital signs, blood pressure, heart rate, and temperature. 2 years ago, my 88-year-old grandmother so kindly reminded me of this reality with a 3 a.m. phone call, livid after being woken for a blood pressure check. For decades, across all hospitals, for all patients, whether you're in the hospital for a bump in the head or a severe pneumonia, we've been checking vital signs at regular intervals, every 4 to 6 hours, day or night. At our most vulnerable, when we're sick and in the hospital, sleepless nights increase our risk for delirium. Patients who are confused, who are tired, who are physically exhausted are at risk for falls and fractures. They can't participate in physical therapy. Their hospital course and their healing are prolonged. And instead of going home, too often they end up in a nursing facility. Unsurprisingly, one of the top complaints from our patients is a lack of sleep during their hospital stay. How can we, doctors and nurses, safely and comfortably allow those we are charged to protect to be left alone for so many hours? Yet, in this era of consumer-driven health, it's time to give patients back control. It's time to give them back their nights. It's time to let them heal.
It's time for a sleep revolution. It's time to let sleeping patients lie. We have developed an AI algorithm using deep learning and a wealth of clinical data, over 2.3 million patients, over 5 million patient nights, over 27 million vital signs. We developed this AI algorithm that can safely and accurately predict which patients can be left alone, not woken up, and we can save effectively 50% of their patient nights while only risking 2 out of 10,000 nights. I repeat, with this algorithm, we can give back to our patients more than 50% of their nights. The algorithm has been peer-reviewed at the leading journal in the field, Nature Digital Medicine, We have already provisionally filed a provisional patent. And just yesterday, actually, we received news that one of the major news publications have selected this as a world-changing idea. Our plan is to create an app that will seamlessly integrate into the clinical workflow and will allow our doctors to focus on the more severely ill patients and reduce their workload by 25%, essentially reducing doctor burnout. Using the app, we will allow our nurses to focus on the severely ill patients, and we will allow our patients to enjoy a fuller night's sleep, essentially increasing their patient experience, improving their outcomes, and shortening their length of stay. Our team has developed and silently deployed this state-of-the-art algorithm over 12 Northwell Health hospitals. Over the last year, even during the pandemic, we have monitored how this algorithm performed over hundreds of thousands of medical and surgical patients. And as expected, it remained extremely accurate and safe. We recognize that for some, 2 out of 10,000 nights might be a bit too risky. So LSPL allows the user to adjust this risk level as they see fit. Next month, in our first pilot at Huntington Hospital, the nurses will start receiving our predictions every night at 9 p.m. They will see which patients on their floor that can be left alone, forgo their vitals, not wake them up, and they can give them that most rare of treats, 8 hours of uninterrupted sleep at a hospital. With this seed funding, after Huntington Hospital, we actually are in talks with 5 more Northwell Health hospitals, and after that, we're going international to UK and to the Nottingham University Hospital. With this seed funding, we will support the pilots. For these pilots, we will build our product and engineering teams, and we will build the LSPL app.
Every year across the United States, the vast majority of the 160 million hospital nights are interrupted. 2 years ago, my grandmother suffered that fate. Next week, it may be your family, your friends, or you. We're all patients one day, and in that very moment, we'll all heal better with 8 hours of uninterrupted sleep. This is the first stop on a journey to leverage the expertise and data of the largest health system in one of the most diverse areas of the world, New York. LSPL is one algorithm, a first stop. Our vision is to develop a series of solutions, a platform for health systems focused on creating and implementing actionable insights for patient experience, quality, and care. And we hope you'll join us on that journey. Thank you.
Thank you. Perfect timing. Just on time for us to begin our Q&A session. Any questions from the judges?
I'll start if I may. One very brief question, and then maybe one that is a little bit longer. You mentioned physician burnout. I'm not sure, as exciting as this is, I appreciate the impact it's going to have on physicians who aren't generally rounding through the night. But the other question I'm curious about is whether the data that drives the algorithm is derived during the hospitalization and is specific to that hospitalization, or if there's a broader context regarding other aspects of the patient's lives, comorbidities, social determinants, that sort of thing. So interested in the data sources that in fact are driving this wonderful work.
The algorithm actually uses and follows the trends of the vitals of each patient, and also uses the age of the patient. So it's agnostic to demographic data or their actual reason that they're inside the hospital. So only using that, what that enables us is to create an algorithm that is very portable from hospital to hospital. And we've seen that it's extremely efficient on a very diverse group of population, right? I mean, we're looking at patients in New York, which are very diverse, and it's extremely accurate even on this diverse population.
And just to address the question about burnout and workload, I think that this is obviously it's a big impact for our nurses, nurse practitioners, physician assistants in the overnight period that there's less work to be done. It allows the patients to get more rest, and hopefully the interactions and the experience for the patients as well as the interactions with the doctors, can be better. I mean, I can tell you, having done early morning rounds, after it's very unpleasant, having to talk to a patient early in the morning after they got a bad night's sleep. So I think it could be better. It will kind of help the overall experience for everyone. It'll feed into itself.
Great, thank you.
So this is pretty revolutionary, and I would love to understand what data you can collect about how much patients improve as a result of getting a good night's sleep. I mean, as you know, the science is unequivocal that sleep is a tremendous healer, and interrupted sleep prolongs everything that we want to deal with in a disease. So it would be great if we can find out what are the data you can collect about impact.
Absolutely. And I think that that will be answered in our first pilots. Right now, we're waking up everyone, so really we don't know exactly what is the impact if we would let them sleep. So during our first pilots, we will start letting some of these patients sleep, and we will start to track how much better their outcomes are, how much shorter their length of stay is, how much better is their experience, right? And that is important for a health system, because then it reflects on the value of the health system and on the reputation of the health system. Review scores, Press Ganey scores for whoever follows those. So I think with these pilots, and as soon as we start expanding where we're using this algorithm, these benefits will start becoming more and more apparent. And I completely agree with you. That's why we actually made this.
Well, Jamie and Theo, congratulations, first of all, on recognizing this opportunity. Certainly, sleep at a hospital appears to be an oxymoron and might well be the most rare prescription one can imagine. But I have two quick questions for you. One concerns whether your approach here might not also be identifying patients who do not need hospitalization. That is, if they don't need to be monitored during an 8-hour period, how often do they need to be monitored and for what course? So that would be question one. And the second question concerns the trend toward wearables. The notion of not monitoring, of course, is pertinent, but the notion of monitoring continuously at zero sound, zero interruption, and zero negative impact is another tack that could be adopted by clinicians.
You want to take the first?
Sure. Sorry, the first question was around going home. So to address that question, I think in our initial phase of the model that we've developed and the solution we've developed, it really does it looks at the short-term period of the overnight period. So it is a little bit more of a short-term focus. I think our teams have already been in discussions looking, as I alluded to, this is our first stop on our journey, right? So it's the first of many to come, and I think that we're already looking at these questions around ongoing clinical stability. The ability to, and I think that it's a natural extension of this work is how soon can we get patients out the door, get them home sooner, where they can have their continued healing. So I think it's definitely a really good point, and I think that's kind of our future roadmap for us.
And as it for wearables, I think that's a great point, and we've been exploring that space as well. And what we see is that while wearables, and even clinically minded wearables, not necessarily your Fitbit or your Apple, but devices that are tailored for the hospital are more and more adopted at this point. They are still having some challenges in giving it to every single patient because they cost quite a bit. And also sometimes they're not always that accurate for a lot of different reasons. So for that reason, we don't see vital monitoring from the nurses going away anytime soon. We would just hope that it would go away during the nights when we want to sleep.
I would also add, from a cost standpoint, putting wearable patches, while it sounds very nice, it's a very large extra cost for health systems. And I think one of the major goals, and we're involved in some of that work, looking at the wearable space, is who should have wearables, and how do we respond to those wearables, and how do we interpret that type of data? But most patients, I think, actually would benefit from less monitoring and less stuff on of them, and less, and at a lower cost. So I think there's a lot of value to be had there.
Thank you.
So I had two questions. One is asking about the types of patients that you're looking at. So, you could say, well, if you're on a regular med-surg floor, you're looking at patients post-thyroid or ankle surgery. They're young and they're healthy. It's probably likely that they don't need monitoring. So how much better is the algorithm? Is the algorithm identifying patients who historically nurses think are risky or are more likely to be unstable? Second question is, do you need to get vitals from the patient for a set amount of time before the algorithm can pick up? Since it sounds like you said the input was just the age of the patient. So is the algorithm saying, okay, I checked the vitals these first 3 times, I see very little variability, so now this person is less risky for variability later on?
You want to take the first one?
So to the first question, I think the current state right now is that largely we're indiscriminately waking people up, right? And so we have all this rich data to see who actually was woken, that everyone was woken up, and we see who actually and truly was stable. I agree with you that there's a lot of cohorts in the hospital that are naturally more stable than other cohorts. But I think what's nice about our algorithm is that it scales to the entirety of the hospital, and it instead of having to put the burden and the onus of trying to think about each individual patient one at a time, it gives the guidance to the physicians and to the nurses to say, we've identified based upon their vital sign pattern that this patient is likely to be stable and can actually be successfully left over in the overnight period. And we actually are very careful that we look at the calibration and make sure that in different subgroups of patients that it works well, because we do recognize that there are a lot of cohorts.
And then as for the second one, you're absolutely right. On top of the age, it also tracks a certain amount of vitals. Right now, we've limited this window to a day worth of vitals that it tracks over and sees how variable they are. The logic of the algorithm, of course, is a bit more complicated because it is a deep learning LSTM neural network, so it's slightly different, but essentially it looks at trends and it looks at trends of vitals and how stable somebody is, and it is quite accurate based on that.
Awesome. Well, that's our time. Thank you so much, team Let Sleeping Patients Lie.
Thank you so much for your time.
Thank you.
Thank you.
Well done, team number 2. And now, our final group in the care delivery category. Please welcome team number 3.
Can deep tissue pressure injuries be detected before they can be seen on the surface of the skin? Good afternoon. My name is Alina Siegel. I'm a physical therapist with 20 years experience on acute care at Staten Island University Hospital. I see a lot of patients with many risk factors for developing deep pressure injuries.
Good afternoon. I'm Anne Marie McDonough, Senior Director, Rehab Medicine. We run a comprehensive inpatient rehab program. People who've had strokes, head injuries, amputees, all prone to pressure ulcers.
Although many pressure injuries are preventable, they continue to be a major problem in all healthcare institutions. The gold standard for skin assessment in 95% of healthcare settings today is still visual inspection.
You heard that correctly. We still use paper tape and Q-tips to measure ulcers.
When a patient arrives at the hospital with these presentations, please refer to the upper left corner on the slide. Deep pressure injury not yet seen on the surface of the skin, or stage 1 pressure injury on darkly pigmented skin. They will likely be missed, and once they break through the skin, Medicare will classify them as hospital-acquired pressure injuries and not reimburse them.
So how big is the problem of pressure injury? I'd like you to hear some statistics. Do you know pressure injuries are so common they occur in 2.5 million people annually? Do you know these common preventable pressure ulcers are on the rise in hospitals as other preventable events like falls and like adverse medication errors are on the decline? Do you know that pressure ulcers are the most common harm event in a hospital stay? Do you know that pressure ulcers are so preventable that CMS classifies them as a never event, that they should simply never occur? Also, pressure injuries are so preventable, CMS will not reimburse hospitals for the cost of the care and treatment of a pressure ulcer. A pressure ulcer injury, such as our deep tissue model you see here, we teach our PCAs and nurses with this, and deep tissues below the surface of the skin can cost up to $150,000 to treat. The present standard, the gold standard of inspection, is simply paper tape and ruler and a Braden score scale that I use as a nurse at the bedside. Also, deep tissue and stage 1 pressure ulcers are very difficult to detect on very darkly pigmented skin. It's also another clear racial disparity in healthcare. Wound treatment protocols like frequent turning and positioning are very easy to implement. What our industry needs is the ability to detect earlier and launch treatment earlier.
So can we detect pressure injuries earlier? The National Pressure Injury Advisory Panel states that skin and body temperature correlate with pathology. Infrared thermography detects that skin and body temperature changes. What I have here is a industrial-grade infrared thermography device, and it's detecting my skin temperature right now on my hand. So red indicates warm temperature, the green, yellow, blue indicates cooler temperature. 2D infrared thermography is finding its way more and more into the medical field, but there are a lot of limitations, such as the lack of the 3D capability and the prohibitive expense. We propose to co-develop a non-invasive, non-contact 3D infrared thermography device that will provide the third dimension depth information. This will enable mapping of the temperature and size of the wound on and under the skin. This information will be sent to the electronic medical record. This information will help clinicians make an earlier diagnosis before pressure injuries break through the skin. Once there is a diagnosis, interventions themselves are simple yet very effective to do. Frequent turning and positioning, a specialty mattress, specialty cushion, and dressing. Adopting 3D infrared technology to the medical field, embedding it into the workflow, will give clinicians an easy-to-use tool to diagnose wounds, monitor healing, and address a very costly problem. We propose to bring this 3D infrared technology into the healthcare field. With the seed finding, our team proposes to identify and partner with an industry leader to co-develop a technological solution with our clinical protocols wrapped around it. We propose a powerful, portable, non-invasive, bedside, EMR-connected device that nurses can use from one shift to the next to detect and monitor the healing process and adjust treatment protocols in order to improve patient outcomes and decrease financial liability. Co-developing this technology will help make pressure injuries truly a never event.
Thank you so much, team. So my question is, how difficult is it to go from 2D to 3D? There are already 2D devices out there. Why aren't those manufacturers creating the 3D devices needed for pressure ulcers?
That's right. Thank you for the question. 3D would involve, first of all, a depth camera, and it's easy to include a depth camera to the setup where you already have the infrared camera and the digital camera. You just add the infrared. That gives you the depth. That will give you information about the surface landscape of the wound. In order to see under the skin, that's a different question. So this is something that such industries as the defense, automobile, and aircraft are working on. So we might have to partner with someone in that industry in order to address that question. In addition, there is a third aspect to the 3D that we will be able to provide, is actually mapping the whole area with a 3D video that will be able to be converted to something like an avatar in the electronic medical record. As you notice on this model, it's not enough just to take a static 2D picture of one injury or another injury. What you need to see is an overall picture. So if you take that camera with the infrared, the digital, and the depth capabilities, you can take an overall video of the presentation, send it to the EMR so that everyone can look at it and have a complete picture of what's really going on.
To highlight what Alina is saying, we're always concerned about wound tunneling, and you probably can't see it too well, but as my finger goes in here, this is a tunnel. And what happens is we come in and the surface looks fairly healed, but there's something going on underneath, and all of a sudden it explodes, and then days later it gets bigger and bigger and bigger. So if we know earlier depth, 3D would bring depth, that would give us a lot more preventive strategies or earlier intervention strategies.
So I've got a couple of questions related to what was already raised. One is, have you actually examined the sensitivity and specificity of 2D versus 3D? And then the second question is, as magnificent as this is in the inpatient setting, I certainly appreciate that. At least for me, my mind, it's probably an obvious point, immediately jumps to the diabetic foot ulcer. and utility in the outpatient domain where, as you know, rates of amputation are horrific. And wondering if you're contemplating this as an outpatient tool, and whether or not my emphasis is sort of on the wrong place, or
Right.
if I'm tracking.
Now, the
with you
concept,
guys.
honestly, should be it becomes a patient-friendly handheld tool. If we get to that point where we start it within the hospital setting, nursing home setting, and then become a handheld. There are some 2D devices out there, to your point. Right now, we did a literature search, we looked at them. A lot of these 2D apps are very rudimentary. There's no correlation across them in terms of quality. A lot of them just tell a patient to snap a picture that most looks like what you have. So there's really no good industry standard or ability to detect, diagnose type of device there right now.
And also to add to that, a lot of the 2D infrared devices that are available, they do not provide the depth picture. It means the nurse needs to take the applicator and check the depth physically. So this is not actually a non-invasive device. You need to do an invasive procedure in order to deduce the depth of the wound, in order to calculate the volume of the wound and get more information for the EMR.
Right, the innovation here would be the depth, being able to map the depth.
Understood. And I'm sorry. And has a prototype been tested on the diabetic foot yet?
I'm sorry, go ahead.
Right now, in 3D models, there is no 3D model out there. There's some industry in the military, in the auto industry, and the aircraft industry. There's some prototype types of things, but they really don't exist in 3D on the market.
And we're referring to looking at the wound under the skin, actually referring specifically to the deep tissue pressure injury before the skin breaks. So for that, we're looking at the 3D that looks under the skin. However, looking at the wounds on the skin, the 3D technology exists already. It just needs to be put together. Another exciting, just to add very quickly, the footprint of this technology would really be wide. In addition to the pressure injuries, the ulcers, the diabetic foot ulcers, the burn injuries would be great to document using this technology as well.
Early surgical site infection, you could detect the heat before the infection rises up to the surface.
And patients with amputations. Again, that capability of looking at the amputation from different directions and getting a coherent, continuous image, like an avatar you can put in the EMR, it would be very significant for that as well.
The other piece we have to mention here too, a lot of these 2D technologies that exist don't have any good patient security in them. So there's a lot of HIPAA issues too. So part of that 3D would be to be able to have a device that transmits a picture securely, HIPAA securely, and we can keep it in a patient chart. So I'm going off shift, I turn over to the next person. We're all working from the same blueprint. You know, we all know who's on first and what's going on with that patient.
Thank you.
I think the thing that I'm most impressed with here is that you're attempting to get ahead of this problem. And my sense with decubitus ulcers and other types of ulcers is that we've always been chasing them. We're late to the party. They're developing in a way that makes them intractable and very difficult to contain. So this essentially attempts to predict where and how deep and the course, if you will, and enables you to actually not only measure that, but also look at different techniques that might be helpful in making a correction possible. One question for you, and this does relate to the scanning notion, which is essential here to understand the depth. Have you considered other technologies besides thermography, ultrasound, for example, which is now becoming much less expensive than ever before, as an alternative to establishing some of these parameters, maybe not as many as you would like?
That's right. That's a great question. And actually, we've read some of the articles, research that use ultrasound as one of the alternative modalities. The limitation here is we're looking to develop a truly non-invasive device that can quickly look at the patient's presentation, detect any temperature anomalies, either an increase or a decrease in temperature would signify inflammation or ischemia. So that would be a truly non-invasive device. Ultrasound, inherently, it needs to touch the skin. So you would have to really, would need specialists to come to the ER, for example, to do that. You would need resources for that, and you would need them to do ultrasound on a very large area to check all the parts of the body involved.
This is very exciting because, as Tom indicated, it's really about going upstream for more predictive medicine, earlier diagnosis, and having the patient co-producing their health in a way. So in view of all that, have you also considered how this could be used at home? So we discussed, in hospital, outpatient. Theoretically, this could be a device, when simplified, that could be used at home. Have you looked at that?
Absolutely. It could be as simple as like a glucometer. We give patients glucometers at home. If we could get the technology concise, portable, it has 1 million chronic care uses. A lot of these are chronic care conditions, and they need monitoring. It's not a one-time event for most of these patients. They come in and we see them frequent flyers over and over and over. If you could set up treatment protocols, self-monitoring at home, they could take charge of their disease and prevent further breakdowns. Absolutely.
Sorry to interrupt, but that's our time. So just wanted to thank you both for presenting today.
Thank you.
And yes, thank you to our IRT team.
Great. Thank you for listening.
Thank you very much.
Congratulations to all of our Innovation in Care Delivery finalists.